Hey guys, welcome to Med 10. So in this video we are going to look at the pharmacology part of the local anesthetics. First we will understand what are local anesthetics. So local anesthetics are those drugs that cause reversible loss of all the sensations in the part supplied by the nerve. So wherever we apply the local anesthetic, it should cause reversible loss of all the sensations. Now let's look at the classifications of the local anesthetics. So local anesthetics will classify them into surface anesthetics and injectable anesthetics. So what are the surface anesthetics? This classification is according to the clinical use. And what are the surface anesthetics we have? We have cocaine, lignocaine, tetracaine, benzocaine, and proparacaine. Then what are the injectable anesthetics we have? In that we have three types. We have the short acting, intermediate acting, and long acting. In the short acting we have procaine and chlorprocaine. In the intermediate acting we have lignocaine, mepivacaine, articaine, and in terms of long acting we have tetracaine and bupivacaine. So according to the clinical use, we are going to classify the local anesthetics into surface anesthetics and injectable anesthetics. So surface anesthetics we use cocaine, lignocaine, tetracaine, benzocaine, and proparacaine. And injectable anesthetics we divide them into short acting, intermediate acting, and long acting. In terms of short acting we have procaine and chlorprocaine. In terms of intermediate acting we have lignocaine, mepivacaine, and articaine. In terms of long acting we have tetracaine and bupivacaine. Now classification according to the structure. So there are basically two types of structures. We have either the esters or amides. In terms of esters we have cocaine, procaine, chlorprocaine, and tetracaine. As you can see, all the esters contain one I. So this is an important point to remember. Esters contain one I in them. So cocaine, procaine, chlorprocaine, and tetracaine, they belong to ester group of local anesthetics. Then we have the amides which are the lignocaine, bupivacaine, prilocaine, and articaine, and these contain two I's in them. So what are all the amides of local anesthetics we have? We have the lignocaine, bupivacaine, prilocaine, and articaine. So now let's look at the important aspect, which is the mechanism of action of local anesthetics. So moving on to the mechanism of action of local anesthetics, firstly we'll begin with the injection of local anesthesia. So when you give the local anesthesia, what does happen? It penetrates the nerve membrane and enter the axon. So we have the nerve membrane, right? So inside the axon it penetrates the nerve membrane and enters the axon. Then after entering the axon, it gains access to the open state of the sodium channels. So we have open state sodium channels in the axon, and it gains access to the open state of the sodium channel. After gaining access, it blocks the voltage gated sodium channels from in the inside, that is the axon. It blocks the voltage getting sodium channels from the inside. Then after blocking it, it tightly binds to the inactivated state and prolongs the inactivated state. So after binding to the sodium channel, it tightly binds to the inactivated state and prolongs the inactivated state of the sodium channel. What happens if it prolongs the inactivated state? It prevents the entry of sodium ions into the neuron. So when you block it, it prevents the further entry of sodium ions. So thus it decreases the rate of depolarization. So the rate of depolarization decreases it. Finally, it prevents the generation of action potential. Thus, conduction of the impulses to the CNS are completely blocked. So, by decreasing the rate of depolarization, it prevents the generation of action potential. Thus, finally, the conduction of impulses to the CNS are completely blocked, thus producing the local anesthesia in the given segment where we give. So it produces local anesthesia. So we are revising the mechanism of action of local anesthesia once more. Hear it carefully. So after the injection of local anesthesia, it penetrates the nerve membrane and enters the axon. It gains access to the open state of the sodium channel. It blocks the voltage gated sodium channel from the inside. After tightly binding the inactivated state, it prolongs the duration. Finally, it prevents the entry of sodium ions into the neuron by decreasing the rate of depolarization, thus preventing the generation of action potentials. Finally, blocking the conduction of impulses to the CNS, thus producing the local anesthesia. That is the given effect. Now we look at the what are the different factors that affect the local anesthesia. The first one we'll discuss about the plasma protein binding. So higher the plasma protein binding, longer the action of the given local anesthetic. If the binding to the plasma protein is very high, then the duration of the action of the given local anesthetic will also be very high. Then following the next factor, that is the rate of diffusion from the site of administration. The rate of diffusion from the site of administration depends mainly on the concentration gradient. So again, higher the concentration gradient, greater are the chances of diffusion and from the site of administration. administration. And the third thing is the lipid solubility. So again, as you know, higher the lipid solubility, more the potency of the local anesthetic. So lignocaine has more lipid solubility compared to the procaine. Then finally, presence of vasoconstrictor. So presence of vasoconstrictor prolongs the duration of action of the local anesthetic. So how does it prolong? So combining vasoconstrictor with the local anesthetics, we have few advantages. So what are those advantages? Number one is the slow absorption. So as it vasoconstricts the given vessel, it blocks the flow of local anesthetic to other parts, thus containing the local anesthetic in the given part. So it directly helps in prolongation of duration of the local anesthetic. As you can see, prolonged duration of the local anesthetic. Then finally, it decreased bleeding in the surgical fluid. So by vasoconstriction, it causes the vasoconstriction of the blood vessel, thereby decreasing the bleeding in the surgical fluid. Finally, the third advantage is the decreased systemic toxicity. So will prevent the local anesthetic from entering into systemic. So finally, by preventing that, it decreases the systemic toxicity. Then what are the disadvantages we have by combining with the vasoconstrictor? It can cause intense vasospasm and ischemia in tissues with the end arteries. So in tissues with the end arteries, it can cause intense vasospasm and ischemia. By it can also cause gangrene. The second disadvantage is the absorption of the adrenaline causing systemic toxicity. So whatever the adrenaline we are combining with the lignocaine and we are giving, it might enter into the systemic system and causes all different side effects such as increased blood pressure and everything. Then it also causes delayed wound healing by causing the reduced blood flow. So when the blood flow to the wound is cut off, it causes delayed wound healing. So these are all the advantages and disadvantages of the combination of vasoconstrictor with the local anesthetics. So yes, thank you guys, thank you for watching the video till the end. Make sure to subscribe and hit the like button, and if you like the video, make sure to share it to your other friends who want to learn more about the pharmacology part. Thank you, and I'll see you in the next video. Bye.